Hello, and we welcome you to our second Thoracic Surgery Clinics podcast. Thoracic Surgery Clinics is a quarterly publication consisting of review articles devoted to a central topic important to general thoracic surgeons. The series and the podcast can be found at www.thoracic.theclinics.com. I'm John Vasallo, the managing editor for this series here at Elsevier, and for this second podcast, we will be discussing the May 2022 issue on lung transplantation. Lung transplantation involves a multidisciplinary team, and here with us today to discuss many of the articles in the edition are the two editors of the issue. One is a thoracic surgeon and the other a pulmonologist. Let me introduce our editors. Dr. Jasleen Kukreja, Professor of Surgery, Program and Surgical Director of Lung Transplantation, and Dr. Aida Venado, Assistant Professor of Medicine and Transplant Pulmonologist. Both are from the University of California, San Francisco, where they perform about 80 transplants a year. Our host will be the consulting editor of the Thoracic Surgery Clinics, Dr. Virginia Lytle, Section Chief of Thoracic Surgery and Medical Director of Thoracic Surgery at Intermountain Healthcare in Murray, Utah. Welcome to all three of you, and over to you, Dr. Lytle.
Great. Well, welcome. Thank you, John. And thank you very much, Jasleen and Aida, for making the time to record this podcast today. I want to also extend my gratitude for you guest editing this issue of Thoracic Surgery Clinics. We could have discussed one of many wonderful contributions from our invited authors. You did compile a thorough compendium of current topics in lung transplantation, which is an ever-evolving field, as we appreciated during the recent AATS meeting in Boston, where the president was Dr. Shaf Khashoggi, a leader in lung transplantation. So I'm really glad that you were able to have a timely introduction of your issue to overlap with that. So first, I'd like to just start off and ask you, each of you individually, how you got interested in the field of transplantation. Let's start with you, Jasleen.
Thank you, Jenny. First of all, for inviting us to be guest editors for this section. It was really a wonderful experience, and working with Aida was really great as well. I've done these sections before, but I've only done them by myself. I think this was twice as much fun this time. So thank you for that. Now to your question, how did I decide on that? I think for me, the most important thing was I liked the complexity of this operation. I like the fact that it required me to not only use my surgical, but also medical skills. It's a multidisciplinary approach in pretty much all of it. And I was very lucky to have been trained by Dr. Sugarbaker when he was still at Brigham and Women's Hospital. When I first told him I was going to do lung transplant as a career, he thought I was crazy. Given the unpredictable hours, mostly nighttime operations, and in those days, and I'm gonna not mention when those days were, the outcomes weren't that great. So, but here I am. And to be honest, even after I've performed, I think over now 500 lung transplants, to me, each operation is as exhilarating as the first one was. And I still hold my breath until the patient takes their first breath on the table. And it's the moment of truth for them. It's very satisfying. I feel very fortunate to be able to do what I love. Not many people can say that and be paid for it. So here I am. Thank you.
That's wonderful. That's wonderful. And Aida, first of all, how long have you been working with Jasleen? And secondly, how did you get interested in the field of pulmonary transplantation?
Hi, Jenny. Well, first of all, thank you again for inviting us to co-edit this issue. It was such a pleasure working with Jasleen in this issue. Definitely a lot of fun. I learned a lot. So I have been working with Jasleen since 2015. That is when I came to UCSF. Initially for lung transplant fellowship after I had finished pulmonary and critical care fellowship in Alabama, where I trained. So it has been wonderful to go from being the transplant fellow to then, develop into one of the transplant attendings. It definitely has been great to work with a multidisciplinary team that just works so well together, like so tight-knit. And how I got into this, back when I was doing pulmonary critical care fellowship, I was very interested in interstitial lung disease, which often leads to pulmonary fibrosis. So these are patients that unfortunately often die from respiratory failure. And I had several patients that died or that they were extremely sick. And when I learned about lung transplantation and how these sick patients could have an opportunity to a new life, it just made me so happy that there was something else that I could do for them. And that's when I decided to become a transplant pulmonologist. And my practice actually involves both interstitial lung disease and lung transplants. So several of my own patients I refer to our transplant team and help them get through the process. And it's just such a joy to see that these patients have a chance to extend their life and improve its quality.
Well, that's wonderful, and I'm really glad that you two are involved in this, and I hope you can attract more trainees to pursue this field, because there's always a need for more folks to be lung transplant surgeons. There's always jobs available, surgeons out there. So I have some questions, and we'll start off with the first one about the ARDS contribution. You invited doctors Ankit Bharat and Konrad Hetzenecker, I hope I'm pronouncing that correctly, to write about transplantation for ARDS. And with a relatively high incidence of ARDS in the United States at about 200,000 cases a year and an overall mortality rate of approaching 50%, ARDS is obviously a serious critical care issue. So I have two questions on this topic. As we know, some patients will recover from ARDS. Please give the audience some guidance on patient selection for lung transplant for ARDS. And what are the criteria for determining eligibility? And how long do you wait before considering this a potentially life-saving option? Aida, you want to start?
Sure, I'll start, but I'll then defer to Jaslene, since she definitely gets called into these cases pretty early. I think that first of all is that, unfortunately, some patients are not going to be eligible for lung transplant from ARDS and unfortunately are going to die. And I think that is the first reality that is hard to deal with. But with that, we have to recognize the instances in which there is hope and act very expeditiously. I think that, when we consider when people are eligible for lung transplant, is there any evidence that their lung disease is irreversible? Because of course, if there's a possibility that someone will recover and keep their lungs, they may be better off keeping their lungs than undergoing lung transplant. So we have to determine when is there signs of irreversible injury that can be manifested by an inability to wean from mechanical ventilation after or ECMO after optimal therapy for a long period of time. And this long period of time, there's really not a very clear guideline. The authors that we invited comment on their experience of waiting at least 4 to 6 weeks on maximal support to allow the body time to recover. We certainly agree that a prolonged time may be necessary, even though we don't know precisely how long that may be. Also, if there have been complications and that patients have developed pulmonary hypertension or RV failure from the lung disease that is progressive, or recurrent pneumothoraces or recurrent nosocomial pneumonia from being on mechanical ventilation. I think all of those things have to be considered as when a patient does require lung transplant and is not going to continue to recover just from ARDS. And I'm going to then pass on to Dr. Kukrejec to discuss about what are the things that make them eligible once we have identified who may benefit from lung transplant.
So I will agree with what Aida mentioned. It remains a subject of debate, right? No one really knows how much time an ARDS lung should be given to recover. And there's really no data out there other than case reports to guide us. And really, before the pandemic, up until now, as a general rule of thumb, lung transplant was not really offered to those with ARDS. And it was primarily because ARDS is of infectious etiology, right? It could be bacterial or viral. And very frequently, these patients end up having superinfections with very highly resistant organisms. So there was always a concern that you're going to end up infecting the donor allograft with the same organisms and have organ failure. The other thing is, from a technical perspective, these operations are very challenging given the acute lung injury of the native lung. They develop intense inflammatory response, and having done quite a few of these operations now, it is impossible to define planes. It easily, an operation, pneumonectomy, it takes probably 10 minutes to really cut through the hilum. There are no adhesions whatsoever. These explants are easily taking us each side up to 2 hours to dissect. So just to kind of give you a, pictorial insight into how these operations have been. So, but leaving aside the one-off cases of lung recovery, after prolonged support, most will agree that as long as patients don't have complications such as BPF, what Aida mentioned, abscess, necrosis, et cetera, I think our general rule is similar to the authors we invited, 4 to 6 weeks wait time. And we have tended to, as have others, both in the US and outside, these patients tend to be younger than some of the pulmonary fibrotic patients that we transplant for. They, generally speaking, have no comorbidities and were in good general health condition. And they usually also have limited organ failure in the sense of just one organ system involvement. And more importantly, we think that they have good rehab potential after transplant. One of the debates that continues is about first percent consent. I don't know if there's any decisions. I think it's very center specific. Our center tends to want to have first percent consent from the patients themselves as opposed to family members. Although historically we've done a couple where we receive consent from the caregivers, but when the patient finally was awake following transplant, he was not entirely happy with it. So we've been somewhat shy of not having a first percent consent. I think with the COVID pandemic, I think a lot more data is going to become available. And I think now we will finally be able to make some informed decisions in the coming years. So we'll see.
Great, thank you. Can you give us just a brief comment on the outcomes of lung transplantation for COVID-19 associated ARDS?
Sure. I think we're early in this, of course, right? And the data is still emerging, but I think what we have so far is the early outcomes. The early outcomes appear to be comparable to the outcomes of chronic lung disease patients who undergo lung transplantation, who may be as sick as the COVID ARDS patient, but not with COVID ARDS, right? So outcomes appear to be similar. We've done about 10 transplants for COVID ARDS patients who were ECMO bridged to transplant over the last year, and we've seen the similar outcomes as well. And I think the next 3 to 5 years will give us more insight into what the long-term outlook is going to be for these patients. I think the other thing that would be important would be not just the survival, but quality of life should be studied as well in these patients. So.
Yeah, I would like to add regarding that last comment of quality of life that Jesslyn made, that I think specifically for these COVID ARDS patients, they were often patients that were completely healthy beforehand. They had like no underlying lung disease. And so waking up to the reality of having received a lung transplant and the change in lifestyle that means, it is somewhat of a shock for them. So I think that one thing that will help improve the long-term rather than short-term outcomes of this transplant is be having more psychological support available for these patients to adapt to their new reality. I think that otherwise, we could like really spend a lot of time and effort upfront in getting them through the acute period, but like if we don't provide that counseling going forward, they may not achieve quite as good long-term outcome as we all wished.
That's a good point. All right, moving on to another topic. You invited Doctors Berry, Ali, Seipel, and Kreisel, transplant colleagues from Toronto and WashU, to contribute a chapter on centralized organ recovery and reconditioning centers, another hot transplant topic that was presented by Dr. Seipel at AATS. Please explain what specialized donor core facilities, also known as SDCF, are, and the pros and cons of applying this model of donor management and organ recovery. You want to start, Aida?
Sure, I can start. So these like specialized donor care facilities, they're really centers where there is a team that is dedicated to provide expert care to the donor. At this point, they are really brain-dead donors that get transported to these centers, and they have a team that consists of nurse coordinators under the guidance of a physician that they have expertise in optimizing organ recovery, meaning preventing ventilator-induced lung injury, managing ventilator fluid status pretty carefully, performing necessary bronchoscopies to clear secretions, getting culture data, treating with antibiotics. So really trying to preserve the function of these organs of brain-dead donors. And then finally, also doing the procurement and getting these organs offered to transplant centers. So the pros that they have is that they can really improve efficiency because the donors are expertly managed and they can increase recovery rate and reduce the cost in the long term because all of the care is being done by nurse coordinators and physicians that are specifically dedicated to the care of the donor, as opposed to needing to utilize resources of different hospitals, anesthesia resources and surgeon resources of different hospitals. The con is that it really requires a very high startup cost because setting up these facilities from the get-go, getting all the training that is needed for the personnel of these teams is really high, and also maintaining these cost-effectiveness approach requires having a really high volume of donors overall over a long period of time.
Thanks. Jocelyn, do you want to elaborate any more on that, or I can move on to the next question?
Yeah, I think I think Aida covered most of the aspects of it, but I'll add a couple more things. One, I am pro SDCF for the following reason, in addition to what Aida mentioned. As you know, I mentioned already what Sugar Baker said to me was that, why would you want to do this? Unpredictable hours, blah, 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 right? So there's now enough studies out in both medical and surgical literature that there's significant burnout in physicians, right? So, and in transplant medicine, it is more so, right? There are not that many surgeons who take call or are on transplant teams, so there's a significant call burden, nighttime, long, complex operations, right? It's very emotionally draining, not only that, but also physically draining, right? So by moving to this, specialized donor care facilities, I think as St. Louis, which was the first center in the US that started this program, they have now pretty much entirely moved to daytime operations. Right, so that would help with the surgical or the overall team burnout. Not to mention, there are now studies out there that show that doing these complex operations during daytime have better outcomes. It's survival outcomes, and also the post-operative comorbidities that we've seen they're reduced if the operation is done during daytime. So that's one thing. And the other, in terms of cons, what I think is that as much as I'm in favor of this model, but there's no oversight of these care facilities, right? So there are 12 of them right now in the US, and there's some in Spain and Canada as well. But when I look at the US care facilities, each facility has their own protocol. There's no standardization. And it becomes very difficult sometimes to request studies or do studies. I think there has to be an oversight, and I think the care should be standardized across these facilities, so it seems almost seamless. So those are the things that I would recommend that happen. So,
and is that a matter of UNOS coming together to provide those guidelines, or how does it work in the lung transplant field?
That's a very good question. I think UNOS has contracted this out to AOPO, and I think there has to be some either governmental or even from a UNOS, a separate committee that oversees this. And currently there isn't such effort being made. So,
got it. Okay. All right, I'm going to move on to another topic here. In general, thoracic surgeons, we all have to work very closely with our anesthesia colleagues, more so than our general surgeons do. And for lung transplantation, communication and collaboration is integral to patient outcomes in particular. So, Jocelyn, why don't you elaborate on some of the key points of discussion between the surgeons and anesthesiologists to optimize postoperative allograft dysfunction and extrapulmonary complications? Like, what are some of the 3 to 5 bullet points perhaps that you share with your anesthesia colleagues? And I know you have a dedicated team, I hope, all the time whenever you do this, so that helps. But
I think you're absolutely correct. I think I believe that over communication is better than under communication. So, and yes, we do have dedicated team, and I think most programs probably do. And PGD obviously is the dreaded complication, and in the first 30 days, that's the most common cause of death in these patients, right? So you're absolutely correct. The stage can be set in the OR, and communication is key. So there are things that, in terms of intraoperatively, that we can do. One of the things would be fluid management. We tend to keep these patients somewhat on the dry side, and our anesthesia colleagues do a really great job of using fluids judiciously. I think the other key point is, depending on what kind of case it is, if it's we are expecting blood loss, I think it is very important to stay in close communication, keeping our anesthesia colleagues abreast of how much blood loss we're experiencing, because blood transfusions can also cause allograft injury. And similarly, I think it would be important for the anesthesia colleagues to check in with the surgeon to make sure that before they give any transfusion to the patient. And I think I tend to be one of those people who tolerates a much lower hemoglobin for many, many, many reasons, as opposed to our anesthesia colleagues. And I think having a dialogue there is extremely important. One of the other factors, I think, in my opinion, that I think is very, very important is management of pulmonary hypertension and RV dysfunction in the OR. A lot of these patients are at high risk for having PGD, since pH is a risk factor for it. So management of the right ventricle, both during and at the end of the operation, could really set the stage for postoperative management. If TEE here is very, very useful. Our center, my practice has been, we don't use PA lines. We pretty much entirely depend on TEE assessment for that. So having a close communication with the anesthesiologist and in managing the RV both during and after is important. For instance, if I start a case with a patient with severe pulmonary hypertension who had not been already on ECMO, and if during dissection patient starts to develop RV, signs of RV failure, I would much rather deploy ECMO sooner than later, before even the organs get in the operating room. So those kind of things I think really can be very helpful in setting the stage. So. Oh, in terms of the other organ systems, how do you keep the extrapulmonary complications at bay? I would say, again, close communication with your anesthesia colleagues. For instance, from my cases, I'm constantly communicating with them, staying on top of their metabolic demands, asking for ABGs, lactate, base, to ensure that patient has good end organ perfusion and not have any other problems besides the lungs. So
you referenced ECMO. Could you just comment on some of the advantages and disadvantages of using intraoperative cardiopulmonary bypass, and how are there some patients you just know from the get-go you should just put on bypass, versus VA or VV ECMO?
That's a very good question. There are no randomized trials, as comparing full cardiopulmonary bypass to ECMO support intraoperatively. But several groups now have shown that benefits of converting or not converting, actually, to support the patient on ECMO intraoperatively. And some of those benefits have resulted in improved length of stay in the intensive care unit, total length of stay in the hospital. They have less postoperative complications, including reintubation rate, renal failure, et cetera. And most importantly, several studies have now shown survival advantage in patients who are supported on ECMO compared to full cardiopulmonary bypass. So I think the trend is certainly more and more programs are switching for full cardiopulmonary bypass to ECMO support. VV versus VA ECMO, I would say that our practice has been primarily veno-arterial ECMO support, and think most of these patients, at least in the US, are fibrotic patients and they have secondary pulmonary hypertension. So we end up using VA ECMO support, and so do most other programs. If a patient happened to be on VV ECMO as a bridge to transplant, and if they don't have significant pulmonary hypertension, I think it's reasonable to just leave them on VV ECMO. I forget, what was your next question?
Oh, do you know, is there a subset of patients who right from the get-go, you should just put them on bypass?
Very, very good question. Another one. There are a couple of groups, especially the one from Vienna and our own group. We've seen that by routinely doing lung transplants on ECMO, it actually has survival advantage compared to no support at all. And one of the theories behind it is that we can let the organs then have prolonged controlled reperfusion that could potentially reduce the ischemia reperfusion injury. And I, again, it's theoretical, but we've certainly seen that. And the second benefit I would say is that most of us have training programs, and it really allows us to take the trainee through a case without having to worry about the hemodynamics, et cetera. That's a secondary benefit, but I would say, I think there is an ongoing debate. No one nearly knows what the true answer is, but both our group and the Vienna group are of the philosophy that having a patient on ECMO for all types of transplants has survival advantage.
Great, thank you. And since you mentioned trainees, do you guys have lung transplant fellows?
We don't have dedicated super fellows, but we have the cardiothoracic training program. We've been looking for one. We identified a couple, but because of COVID, didn't pan out. So we do have super fellowship, but currently we don't have one.
All right, Aida, I'm going to ask the next question. Ask you the next question. So infection and rejection, continue to be clinical challenges in all types of transplant, not just lungs. And infection is responsible for 35% of deaths in the first year after lung transplantation, according to one of your contributors. So what are the advances that have been made in the past 10 years or so in reducing the infection complication and minimizing the risk of chronic allograft dysfunction?
I think the main advantage that we have done is having more awareness, in the sense that I think that it took a while to realize how high is the risk of infectious complications for these patients. That is really the highest in that first month, and what type of organisms we're going to see, the nosocomial infections, donor-derived infections. And then also not forgetting that the next 6 months, they're still going to be profoundly immunosuppressed, even though they may be looking fantastic and ready to get on with their life, they're still profoundly immunosuppressed. And that's when they're going to be at risk of some organisms that we typically see in these just very immunosuppressed populations, Aspergillus, Pseudomonas, not necessarily community-acquired bacteria just yet. But even though after they pass this fear of profound immunosuppression, the rest of their lives, they're still going to remain immunosuppressed, even if not as much. And then we're going to start seeing this increased susceptibility to community-acquired infections, especially pneumonia. So I think the biggest advantage has been awareness of how high risk patients are, because then that allows people to prevent. There's only so much that can be controlled in terms of reducing immunosuppression, but then it can be prevented with prophylaxis. And clearly, pneumocystis jirovecii prophylaxis has been able to decrease pneumocystis jirovecii pneumonia over 90% in solid organ transplant and hematopoietic stem cell transplant. So also the institution of antifungal prophylaxis and CMV prophylaxis, recognizing that people have higher and lower risk of CMV reactivation. So I think pretty much is awareness of how immunosuppressed patients are and taking preventive measurements with prophylaxis. I think that is what has allowed advances in terms of infection. Now, I think that really the crux of the issue is if at some point we were able to really learn more about the immune reaction to the graft and assess immunosuppression at a level that we could minimize it just to be able to keep the graft protected, but avoiding this over immunosuppression and this additional risk of infections. I think that is what really the field needs, like better understanding of how little immunosuppression a patient can get away with.
So yeah, you're making a little bit of reference to areas that research could address. So what if you well, I should ask you what kind of research you may already have ongoing in this area. And if not, what would you suggest to our audience to pursue as or to focus on for research?
I think that, in here, at least at UCSF, I think our colleague that does most of immunology research is Dr. John Greenland. And so certainly in other colleagues in other institutions, they have people that are dedicated specifically to understanding the immune response. So I think, understanding lymphocytic bronchiolitis, understanding the role of specific cell types like the natural killer cells, I think that type of research is really what is going to be able to allow us to target immunosuppression in a better way. But I don't think that this will be fast. They have been doing this research for decades, and we are still not close to determining how immunosuppressed the person is. I think that the close that we are coming now is, we of course monitor tacrolimus levels. We get a sense of how much is too high, how much is too low. But I mean, there's certainly room to improve and really do individualized, like personal medicine for each of the patients.
So when you have referenced the importance of monitoring for post-transplant infection, it obviously involves a lot of visits for the recipients, and perhaps you can use telehealth now for some of those, and then they can get their blood work locally. But this brings me to my next question, addressing disparities. We had an issue prior to this on social disparities in thoracic surgery for thoracic surgery clinics. And we learned about significant disparities also in lung transplant recipient and donor populations. So, and these can be a lot of it socioeconomic, but also there's cultural challenges. So how can we as thoracic surgeons who are listening to this podcast work to narrow the gap and provide equitable delivery of care to underrepresented minorities with advanced lung disease? You're shaking your head, Aida. So would you like to start?
I can start.
You might have an answer.
I can start. I think the first, the first step is already there, which is recognizing that this disparity exists, because we have to recognize that, like sometimes like the population of donors doesn't necessarily represent the composition of the population of recipients, meaning that not all of the population is benefiting from the organs that are coming, right from that population. And similarly, the healthcare provider a population may not necessarily represent the composition of the population that they are serving. So I think the first thing is awareness that at some point, the population that we serve, like should match in terms of the transplants that are being performed. I think that probably what would help the most is to really have multidisciplinary teams that have people that come from different backgrounds. I think that unfortunately, bias is unavoidable. Everybody has biases, and it is, determined by everybody's backgrounds and the experiences that we all have. But actually having in the room a team of people that have different backgrounds, people see different things. And that allows patients that, to some people, they may be at extremely high risk. They don't think that they can make the support, that they don't think that they can receive the education and take care of these organs. Another person in the team may say, I don't think so. I think we can navigate this cultural, difference and actually be able to support this person. So I think that having diverse teams is the first thing we can do as providers to make sure that we provide the care that patients need. I think second is that we have to have very intentional outreach to the referring providers in this population so that they know that we are able to provide competent care to patients, even if they don't speak the language that most of us speak. And finally, I think we have to have a lot more support for our social workers, because our social workers do a pretty enormous job really trying to bridge that gap with our patients, meet them where they are, trying to find support in their community, resources that may make advanced care as lung transplantation accessible to them. So I think that we really need to do more to support our social worker team.
Well, I know there are gender disparities in this area, so I appreciate that you two women are leading this obviously important topic, and hopefully they can minimize some of the disparities in that. But Jasleen, would you like to expand at all or add anything to what Aida said about disparities, or did she cover it all?
I think thank you. I think Aida really very elegantly covered most of the topics. And one thing I would add is that, inclusivity is extremely critical, right? And what do I mean by that when it comes to these disparities? Our center, like many other places now across the country, if not the globe, are trying to, implement processes to improve inclusivity, right? So one of the things that we identified, in the past, we didn't have any consent forms in any other language, right? It was just English. And now we've gone out of our way to have different languages be available for consents, right? So small steps like that, which may seem small to us, are very large steps forward for these communities. So I think there's a lot of work ongoing, but there's still a lot of work ahead for us to improve this.
Well, I think I've completed all my questions, and you guys, I really appreciate you taking the time to record this podcast, and also to put together an awesome list of chapters for the issue. And I hope our audience will be educated and ready to, or even get inspired again to pursue this field, some of our trainees. And maybe you're inspiring some of your current CT residents to pursue it as well, since you are amazing role models.
Well, I must say, I want to thank both of you for being so available and to give us the freedom to do what we did.
Thank you for joining us for our second Thoracic Surgery Clinics podcast devoted to the May 2022 issue on lung transplantation, volume 32, number 2. The series is available for individual print or online subscriptions. Visit www.thoracic.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter at Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Amazon Music, Spotify, or Stitcher. Thanks for listening.